our plan with this study, and I hope that more and more studies will kind of adopt this, is to work with this wonderful group of our patient partners to come up with materials and shared decision-making tools that could be used by clinicians and patients in a language that they can understand what the study means and what the implications are for that particular patient that is being seen at the bedside, right? Because this results are generated based on thousands of patients' data, but then how do you translate it to that particular person that you're seeing at bedside? All of those are very important things. And
this is the Recovery After Stroke podcast with Bill Gassiamis, helping you navigate recovery after stroke.
Hello and welcome to episode 244 of the Recovery After Stroke podcast. My guest today is Dr. Eva Mistry, who is an assistant professor of clinical neurology and rehabilitation medicine in the College of Medicine at the University of Cincinnati. With a team over 12 sites across the United States, Dr. Mistry is working on a research project that for the first time is specifically looking at how to better support stroke survivors that have had previous disability before they had a stroke. Dr. Eva Mistry, welcome to the podcast.
thank you. Thanks for having me.
My pleasure. Thank you for being here. Can you give us a little bit of background in the kind of work that you do and the research that you do?
Sure. As you know, I'm a stroke neurologist at University of Cincinnati, and I do clinical research in stroke, mostly in clinical trials in the acute stroke space. So kind of optimizing medical management after acute stroke. I'm also kind of involved in novel treatments, both medication-wise and devices-wise of acute stroke. And the types of studies that I do range from kind of development, early phase development of these new treatments to all the way to kind of more late phase comparative effectiveness studies around increasing, equity of, providing these treatments to stroke patients with various, coexisting kind of conditions and things like that. So, but mostly around acute stroke therapeutics from early phase to late phase clinical studies.
How do you become a neurologist in this field? What is the interest? How do you get excited to learn about this type of thing and then help people who you don't know who have had a stroke?
My journey to neurology kind of began very early in medical school. I really liked in all my basic science subjects everything related to brain very, very much, and that kind of I knew that I would do something that was related to brain. And when I was in training and residency in neurology, kind of stroke neurology or vascular neurology was particularly interesting to me because you could really help people in real time by kind of being present, thinking fast, and acting really fast could mean, surviving with disabling deficits versus recovering from a stroke. And it kind of, it really called to me. And that's why I kind of chose vascular neurology. It's, believe it or not, I was going to be clinical vascular neurologist after that, and my plan was to practice in a hospital setting as a stroke neurologist. But I started dipping my feet into research right after some of the very large, device-based therapy trials came out in 2015, and my first kind of question was management after that procedure, clinical management after that procedure, particularly related to blood pressure management. And so that kind of just dabbled through, and I kind of did one study after the other in that space, and then gained some methodologic expertise, and then it kind of just branched out into various questions. I will say that the one thing that has helped the most is a kind of in clinical research, you see patients and it's with an open mind, and that just helps you consider your next research question because you identify the gaps in the way you practice and the data that you have and don't have. And so that has been definitely eye-opening. And in terms of what keeps me going in clinical research is just a sense of purpose thereafter, is to kind of know that the work that I do helps many people and not just somebody that I am seeing in real time at bedside at the moment. And so it just kind of knowing that I'm able to affect, human health at large is kind of gives me a sense of purpose to keep going in clinical research.
Yeah, it's pretty cool. Do you have to be a very curious person to work in your field?
I think so. I think as I had mentioned before, I think you really have to have an open mind about where the gaps are and identifying those gaps, and then definitely curiosity plays a lot of part. But then there's more to it. You can have questions, but then there's about finding somebody who finds your question interesting and the way you communicate to them, especially funders who give you the funding to do that research. So there's a little bit of an art to it about how you write it, how you synthesize your question and things like that. So there are a lot of layers to be a researcher, but definitely curiosity is the first one.
The thing that you've mentioned a couple of times already is the gap. You talk about the gap. We hear about that from stroke survivors a lot. One of the biggest gaps that I'm trying to fill is the one where you have a stroke, you go to hospital, you get patched up, and then you go home. That is a massive gap because every bit of information that's necessary is missing because we've never been here before. We don't know what to ask. We don't know how to solve problems. And there seems to be so many of them, we don't know where to start. And this is what the podcast does. It kind of fills in a few of those knowledge gaps. And what I try and do is paint a picture for people listening about the stories that stroke survivors share, that there's a terrible situation that makes them end up in hospital. Then there's a difficult time at home. And then over time, there's some form of turnaround and some kind of a recovery. And then there's some kind of return to not normal, but return to life. And it follows that path. And it's a very common theme. You see it for most people. The timeline is very different for everybody. There isn't a specific, I can't say to everybody, well, yeah, you've had a stroke, that's 6 weeks, or, that's 9 months, or it's not like a knee injury or some other type of injury, like a muscle injury. So people struggle to go through the process of dealing with the unknowns, all the unknowns about stroke. How do we move on from this? Because they probably have had a muscle injury or a knee injury or some kind of injury in their life, and they've always had that beautiful timeline that they can recover and then get back to life. And what's hard is when you get back, you're dealing with fatigue and you're dealing with all the trauma, perhaps brain surgery, and you're dealing with all those things. And then somebody says to you, you have to exercise. And I know how important exercise is. It is probably, all right, I'm writing a book, and one of my chapters is about exercise and the benefits of exercise. But then for me, exercise was never harder in my life until I had brain surgery. And then it was more important than ever, but then it also was the hardest time to do it. Tell me a little bit about exercise specifically and how it benefits people who are recovering from stroke.
I think exercise definitely kind of helps in in the simplest term, rewiring the brain to the maximum potential that you could have for stroke recovery. Again, as you mentioned, that potential looks different from a person to person. So many factors affect it. I think the biggest factors that affected everything from how it was treated in the acute phase to what happened in the hospital, what kind of prevention treatments were offered, and then what kind of rehabilitation therapies or exercises or speech therapy or occupational therapy has been offered for how long, the doses, different kinds of experimental recovery therapies that were offered, things like that. There's so many variables. Social support after stroke is an extremely important variable that affects people's recovery quite a bit. What kind of caregiving and what situation they've had it. So there's so many variables, and that's why everybody is different in terms of their trajectory of where they go and how they go there. But in terms of exercise, yes, it's extremely important. But we as clinicians also understand that's hard, not just because of the maybe physical disability that's been sustained as part of stroke, but there's a brain injury, and brain injury causes chemical imbalances that in and itself can cause fatigue and mood changes, motivation changes. And so it's all kind of a part and parcel. So oftentimes what our patients also tell us is that, the fatigue is kind of out of proportion to the actual physical limitations. And that has a lot to do with how, the brain is injured. That's the bottom line. And
the fatigue is out of proportion. I love how you explained that, because it's so out of proportion, it cannot even be explained. And sometimes there's a really big price to pay. I remember in my first few days of rehabilitation in Royal Park Rehabilitation Hospital in Melbourne, where I'm from, the 1 or 2 minutes of rehabilitation ended up becoming half a day recovery or longer.
Yeah.
And there seems to be a massive price to pay. And I can see how that can put some people off from getting back up the next day to let's do this again. So it gets better, though. It does improve. Why is it important to get to the limit and then push beyond the limit or the barrier or whatever that is? Why is it important to sort of get there and do it, even though it's really, really hard?
I would say that definitely kind of pushing the barrier is, first, disclaimer that you should always follow your physical therapist and occupational therapist advice, and definitely don't push yourself beyond what they say you should, because like you said, it's about consistency. It's not about pushing that barrier one day and not being able to get up for next 3 days. It's about, consistently doing the maximum you can consistently. But also too, the stroke recovery happens almost kind of, exponentially in the first 3 to 6 months after stroke. And so I would say kind of pushing yourself to the maximum in that early phase and kind of getting the most off that early recovery period is maximally important. And I know that that's the hardest period as well, when the stroke is quite fresh and everything is, frankly, your life has changed, in an instant. And so that's definitely hard. But also that's the kind of the right window to gain maximum benefits of what your therapists are asking you to do. So I would definitely kind of recommend following their advice, keeping at it consistently, not overdoing it to the point that you can't get up the next day and can't do it again. But yeah.
If you've had a stroke and you're in recovery, you'll know what a scary and confusing time it can be. You're likely to have a lot of questions going through your mind. Like, how long will it take to recover? Will I actually recover? What things should I avoid in case I make matters worse? Doctors will explain things, but obviously you've never had a stroke before. You probably don't know what questions to ask. If this is you, you may be missing out on doing things that could help speed up your recovery. If you're finding yourself in that situation, stop worrying and head to recoveryafterstroke.com, where you can download a guide that will help you. It's called 7 Questions to Ask Your Doctor About Your Stroke. These 7 questions are the ones Bill wished he'd asked when he was recovering from a stroke. They'll not only help you better understand your condition, they'll help you take a more active role in your recovery. Head to the website now, recoveryafterstroke.com, and download the guide. It's free.
Tell me a little bit about the project that you've been working on.
So I'm involved in many projects, but the one that I'm assuming you're talking about is the disability grant, and that's funded by the Patient-Centered Outcomes Research Institute in the United States. The project is basically fundamentally just trying to understand the comparative effectiveness of a treatment called endovascular clot retrieval treatment to medical management for patients who have a pre-existing disability prior to their stroke. And so that could be from many conditions, including a previous stroke, or kind of, having a knee replacement or being in a wheelchair for other reasons and things like that. And so we're trying to understand if offering this particular treatment to patients who have a pre-stroke disability improves their outcomes after stroke. And really, this shouldn't really be a question, but it is. And why it is because in stroke, when we do research of new therapies, we tend to kind of exclude patients who have pre-stroke disability. And the reason why we do it is because we want to measure outcomes of these new therapies in terms of how much disability was saved in the long term. And if you include patients who are kind of disabled at baseline, then you reduce that chances of understanding that if there was an improvement in function and things like that. So that kind of translates into gaps in how we offer clinical care to patients who have pre-stroke disability. And so the project is just trying to fill that gap after generation of data to understand if we should be, offering treatment to pre-stroke disabled patients. And in long-term, big picture goal really is to generate data so that the future researchers don't end up excluding patients with pre-stroke disability as a knee-jerk reaction, but really kind of think about what outcomes in this population looks like and how they can use this data to make sure that the stroke research is equitable for all patients in future.
That's a really interesting thing. All right. This is going to sound strange, but maybe not to you because you've been doing some work in this field, but I never considered that. This is going to sound so bad when I say it. I never considered that people with a previous disability could have a stroke. Oh my God, I can't believe I even said that. But it's such a strange thing because you see people who are disabled, you assume they've had a stroke or something like that already, and that's why they are physically disabled.
Mm-hmm.
But it makes sense that they're just normal human beings who are susceptible to stroke. Is there a possibility that people who are previously physically disabled and therefore in a wheelchair are at higher risk of certain types of stroke?
It's a complicated question to answer. So in terms of data, we know that anywhere from 15 to 30% of our patients that we see in the emergency room with stroke have a pre-existing disability. So this is not a small proportion of patients that we're talking about. It's probably fully 1/3 of our stroke population. But in terms of high risk of having a stroke, it could theoretically be the case. I mean, obviously, a lot of these patients, like you mentioned, prior stroke, and that is why they're disabled. Having a previous stroke increases kind of theoretically your risk of having a future stroke. So in that sense, you would, some specific types of functional limitations may kind of increase that risk as well. For example, if someone is wheelchair bound and not moving their legs too much, they can form blood clots in their legs and they could secondarily have stroke from those and things like that. So it is a bit complicated answer. It kind of depends on what the cause of pre-existing disability is, but yeah.
And what was the complication with people that were previously disabled in in including them in these studies in the past? What did people feel was happening? Did they feel that perhaps it was messing with the data, or did it add a level of complexity that was too hard to deal with, or how was it that they were being excluded?
I think it's probably the latter. And the reason is because, as I mentioned, the outcomes of these therapies we measure in a score called modified Rankin score, which is a score that goes from 0 to 6. 0 is no disability, 1 is some symptoms, 2 is kind of mild disability, 3 is moderate disability, 4, 5 is disability, 6 is death. So it's kind of a very disability-centered score. And so the research studies that we have been designing thus far just kind of says that because our outcome is measured on the 0 to 6 level score on what the patient's disability level is, we're not going to include anybody, say, for example, has an MRS 2 or greater or 3 or greater, meaning mild or moderate disability. Because at the end of the day, if you include patients who have a pre-existing MRS of 3, no way at 90 days their MRS is going to be less than 3, which is what the therapy is trying to measure. And so it kind of adds a level of complexity. But what we're trying to do with this study is kind of arm the researchers with the data of what the outcomes or relative outcomes of these patients with and without therapy looks like, so that they can account for that in their research studies and say, hey, if we include patients with disability, maybe we should use this alternate outcome measure for them, or account for this kind of level of change or reduction in the effect that we will see. But we should include these patients because they are quite a bit of a significant proportion of the patients that would be eligible for research. And so you're generating more generalizable results at the end of the day.
And you're increasing the pool of people that you can bring into the study as well.
Exactly.
I imagine that's difficult, trying to find people to bring into studies to give you accurate data or to give you information that you can use to get some sort of an outcome. Is it hard finding people?
Acute stroke research is always a little bit hard because if you think about it, kind of probably patients are at the worst time of their life, their families, and it's just kind of, it hits you like lightning, right? There's no warning. And then you're in a setting in the ER and you're being seen by doctors that you have no rapport with or relationship with. You're probably seeing these new faces the first time. And hopefully I can say for the healthcare community in general that we have the best interest of the patients that we're seeing in front of us. And
I agree.
And that's why we offer research, but it is hard to build trust. It's hard for patients to see this doctor who they've never seen in their life, no matter how much they say that they're saying things in their best interest. It's just hard to build that trust and consent to research studies. And acute stroke research studies are complex. Sometimes it's kind of a life or death type of a situation. So we understand that, and so it is generally harder to enroll in acute stroke research studies compared to, say, for example, cancer research, where you have a pre-existing relationship with your doctor or clinician.
So when you go through a process to come up with the idea for the study, then it gets funded, and then you recruit people to do the study. How long does it take to get to the end of a study like that? How much time and effort goes into that?
Every study is a little bit different. In terms of more stringent funders, for example, PCORI or NIH or things like that, they require from researchers information that is backed by data on how many patients do they expect they will recruit, say in a month or a year, at how many sites. And so they require kind of a very well laid plan on how many patients, how many sites, at what rate. And so with that math, it's going to take us 4 years to finish the study, or 5 years to finish the study, or finish the recruitment. And then there's the follow-up period. Usually for stroke studies, it's about 3 months. So taking into account, we have to build what we call kind of a recruitment and retention plan. It's a whole kind of 5-page document we have to submit to the funders to justify that it's going to take us 5 years based on this calculation, things like that. So generally, it's the grants are about 5 years. Typical grants are about 5 years, but of course, there's no rule that you can't get it done in shorter period. It actually is great if you can get the study done in a shorter period than that.
Once the study's been done and the research has been created and you have some data, then what happens then? What do you do with that data? How do you implement that into, say, a hospital setting, or how do stroke survivors benefit from that? Great
question. So once we have that data, we conduct what we call statistical analysis, and that is also kind of plans for those are usually specified before you start the study to be most kind of robust, that you will stick to what you said you were going to do. And so we do the statistical analysis according to that plan and find out if the treatment worked or it didn't work, or was there safety issues, things like that. And if it worked, did it work better in a certain population versus the other, things like that. Then we publish those results for the scientific community, and we put it up in the clinicaltrials.gov website as well for patients to click and see what the study results were. All of this is done in a de-identified manner, meaning none of the patient identifiers are included anywhere. This is all kind of bulk aggregate data are published so that nobody can kind of go back and trace to a particular patient. So after all of that is done, different things happen. So hope is that the clinicians will read, at least if the studies are published in high impact journals, that they will read it and they will mull it. A lot of times these results are kind of presented at large scientific conferences where a lot of stroke doctors and clinicians attend, nurses attend, things like that, pharmacists. And so hopefully the results are kind of disseminated broadly to the scientific community, that they will start offering to patients. But the funder that I was alluding to earlier, the Patient-Centered Outcomes Research Institute, and our study as well, is kind of very keen on making sure that patients are partners in the study. And so in our study, we work with 3 patient partners. One is a stroke survivor, one is a caregiver of 2 parents who have suffered from stroke, and one is a person who has lived with a cardiac heart condition related disability for her entire life, to give us a perspective of what is it like to live with a disability not related to a stroke, and what would you like happen to you if you had a stroke, and things like that. So all in all,
just a quick break and we'll be right back to the interview. As a stroke survivor, I understand the difficulties of finding the right information about post-stroke nutrition. That's why I developed the course 5 Foods to Avoid After Stroke. While most people are talking about what to eat after a stroke to support brain health and recovery, very few are talking about what you should avoid. To understand courses that are made by a stroke survivor for stroke survivors. Once again, you'll get more than 5 hours of content. All audio is available to download in MP3 format for listening on the go, full transcript of all the content to take notes on or read instead of listen to, presented by a stroke survivor for stroke survivors, also presented by a trained nutritionist and performance coach. You will also get 24 hours of access, lifetime access to courses purchased, and you'll be able to interact with yours truly in the comments section. Go to recoveryafterstroke.com/courses to check them out now.
Our plan with this study, and I hope that more and more studies will kind of adopt this, is to work with this wonderful group of our patient partners to come up with materials and shared decision-making tools that could be used by clinicians and patients in a language that they can understand what the study means, and what what the implications are for that particular patient that is being seen at the bedside, right? Because this results are generated based on thousands of patients' data, but then how do you translate it to that particular person that you're seeing at bedside? All of those are very important things. And yeah.
I'm curious about these types of studies. Often I talk to people about studies and they're done by English people, English speaking people. Do these studies ever get translated into other languages for application in other countries or for uptake by researchers or doctors or patients in other countries?
That is just a great question. So in terms of the primary publication itself, it is usually in English, but this shared decision-making tool, or kind of a summary of results in lay language, in this particular study called Tested that I talked to you about, we have budgeted for translation costs to have those translated in common languages, to help facilitate those bedside discussions. It's not just to other countries. In the United States, there are regions where we have many non-English speaking patients. In fact, we have chosen our sites to have representation of non-English speaking patients, and we have kind of budgeted for translator costs and non-English language consent form translations, and we want those patients in our study, to make sure that it's applicable to all of those patients, not just English speaking patients. So yeah, excellent question.
I know that in Australia, there's not so dramatic amount of populations where English is not spoken at all. I know my parents, when they immigrated from Greece in the 60s, they kind of learnt to speak enough English to get over the line. And there was always, and now there's translators available, not that they're involved in any studies or anything, but every time there's been a hospital visit or a doctor's visit, there's always a bit of a language barrier. And I feel like perhaps they miss out on some things that they would benefit from simply because they don't understand the application to them, because it's being explained by somebody who perhaps is not fluent in Greek. And that's okay. Like, I kind of get it. But then I've interviewed some researchers also from the United States who are based in the border towns, between Texas and Mexico. And it's a completely different world there compared to what it would be like, for example, in New York City or one of the other major capitals. And she deals specifically with Spanish-speaking people. And it was interesting for me to remember that now that we're talking about this and the problem. You're doing this great work, and then there's a whole bunch of people in a community who potentially miss out because of this lack of translation. Now, is it a new thing to have research data translated in different language?
I would say, unfortunately, yes. We should have probably been doing this all along. I think that it's happening more and more as we kind of start becoming aware of the patients and people that we're leaving behind, by not thinking about these things proactively. And on behalf of scientific community, sadly, yes, but I hope that we will do better by making sure that we translate our results in appropriate languages. So for Tested, we have New York City, for example. Mount Sinai has a ton of kind of diversity of patient population, including various languages. We have Miami, a lot of Spanish-speaking patients, LA, a lot of Spanish-speaking and other languages. So we're hoping to kind of tap into that geographic and ethnic diversity to generate more equitable and generalizable results across communities too.
Is it a blind spot perhaps from the funder's perspective? Because you guys go to the funders and you say to them, hey, we need some money. And they say, okay, here's some money for the research. And then they don't say, here's some money for everything else after that. So you're limited, as well as it's just perhaps something that hasn't been considered, because the data seems to be the most important thing. I feel like the scientific community hasn't placed enough importance, just we're talking about in the decades beyond right now, in getting that information out. There seems to be a lot of people who love research, love learning, love discovering, but disseminating information is not necessarily their key attribute. It's not something that they love doing. And it kind of it seems to get lost, and there seems to be a bit of a blind spot in that space. Does that resonate with you, or is that maybe me just going to a different tangent?
I think it definitely. I wouldn't have. It's difficult. So what you're alluding to, it's a science on its own. It's a walk of science on its own. It's called implementation science, of understanding how research results are are uptaken by both scientific community and patient community, and understanding the barriers for why not, if not. And so there's a whole branch of implementation science, and there are particular funders that are interested in implementation studies, the particular ones being PCORI, and a lot of focus on how this will kind of get to the end users, and not just patients. End users can be insurers, for example, right? They need to know and understand what we did, why we did, and what this means to make sure that appropriate treatments and interventions are reimbursed and paid for.
Right.
End users could be clinicians. There are many different types of end users. They could be caregivers of stroke depending on what the study is. So that's definitely one of the focuses of PCORI. There's AHRQ, which focuses a lot on implementation science as well. So there's definitely a whole branch of science that focuses on exactly this. For stroke, I agree with you that we probably haven't tapped into the potential of implementation science to the fullest, and we should. But the research resources are limited, and so I don't want to say that it's a weakness of the funders or anything like that. But I definitely think that that's something that we should kind of try to think more about and hopefully fold into our study designs more and more.
I didn't mean to say anything nasty about the funders.
Yeah.
Of course, we're grateful for them. It's just in my mind, that's kind of what it seems like. But I'm speaking as an observer, somebody completely out of the scientific process. I don't understand it at all, other than I benefit from it. There's no doubt that I benefited from the work that other people have done in rehabilitation. Well, in brain surgery, I benefited from all the things that have ever been done with regards to stroke and recovery from a hemorrhagic stroke. So I'm eternally grateful. I love it when I get to interview researchers such as yourself, and I know that there's challenges. That's why I love to give a voice to people who have a study that they want to tell people about, or give us a bit of an insight. And also, why the other reason I love to interview them is because I think it's important for me to make stroke survivors aware that they should become available for these types of studies, so that they can allow this type of work to be done, so that others who come after us benefit from that work, because we've benefited from the work that other people have done before us. So I think it's really important. The community is one, and we all benefit from that, and we all need to work together. So you've been doing this study now for a little while. How long has the study been running? This study about including people with previous physical disabilities in understanding how they need to benefit from rehabilitation services after a stroke.
We're just getting started.
Oh, great.
And so just next month, so in a couple of weeks, we expect our kind of funding to arrive. And so we've been kind of working on what we call the study protocol, which is kind of the document that outlines exactly how research is going to be done and what are the kind of steps the team needs to take and what they need to assess and at what point, things like that. So that's called the protocol. That's what we're working on right now, submitting to what we call the institutional review board, so IRB approval after submitting the protocol, and that's what we're working on right now. But April 1st is our start date officially, and so we hope to start patient enrollment after all of those steps are kind of completed in the next 4 to 5 months.
And are patients able to enroll early? Are they able to put down their interest for this particular study to be involved in the study early on, or is that something that has to happen later?
The study kind of enrollment happens within just the first, 3 to 5 days of the hospital stay. And so it is a pretty, kind of a subacute study, if you will. So patients present to the ER, kind of get the treatment as standard care, and then after that, they're enrolled in the study to assess what their pre-stroke level of functioning and quality of life was and things like that. And then we follow them after the discharge, kind of collect some of the data on what kind of rehabilitation therapies they received, where they got discharged, what the social support was after discharge. So generating some kind of robust data on that, and then evaluating what their functioning is, what their quality of life is at 90 days after stroke, to then kind of compare those who got treated versus those who didn't.
And how do you plan to enroll these people? Where do you find them? How do you bring them into the project?
So we usually enroll them in the hospital setting. And so every hospital has different workflow on how to identify these patients. But most commonly, there is what we call a stroke code system where a stroke alert gets activated anytime a patient with acute or sudden stroke comes to the hospital. And that might be the best way to kind of identify these patients. And then, of course, the study team will have to then determine if they are eligible for the study based on what their baseline functioning was and things like that, a couple of days into their hospital stay.
And how many people are needed to have the correct amount of people to start this study or to get the right amount of data?
So we are a 12-site study, and every site has what we call a site PI, which is kind of a clinician who kind of leads the study. Every site has what we call a site coordinator or lead coordinator, who is a study staff who helps with the consent, data collection, things like that. And so I would say at a given site, there's maybe a staff of on the ground staff of maybe 3 or 4 people who work on the study. And then there's also the national team, which myself, I have 3 other PIs with me who work with me, and a project manager. But then the team is very big. Like we
Wow.
have an imaging center where they take care of like all the imaging studies that happen. There's the IRB, the central IRB. There's what we call data and safety monitoring board, which is made up of people who kind of monitor study progress and any safety issues that are going on that are independent of the study team principal investigator. So it's the whole, it's a big team of
Huge.
people. It's huge. And then there are patient representatives, as we talked about, that are part of our team as well. And then there are clinician stakeholders that are part of our team to help us make sure that the clinician end users will use the results that we generate and to make sure that we're doing what's meaningful to them and things like that. So it's big.
It's big. It really is big. And it's really something that people like me would never understand how big and complex it is. And it's over 12 sites. So that's excellent that it's over such a broad space so that it can get people from a whole bunch of different backgrounds and different places. I really like that. And then it's going to be a while before we have some feedback from this study, before we have some data. How long do we expect before the data becomes available?
The study is a 5-year study, so it's going to be a minute
Yeah.
before before we see the results. But hopefully we'll enroll faster.
Yeah. It's a big commitment. Hey, I really appreciate you reaching out. Oh, well, and coming onto the podcast to share the information about this type of work. It's really important for stroke survivors to know that in the background, there's a whole bunch of people working for our benefit. I really find that amazing. It's something that I always say to everybody who I interview who's doing research in this space. I feel like it's such a lovely thing that people do. I know it's your passion, it's your work, and you have curiosity, but as the person who's the end user and the benefits from your studies, I really appreciate it. And I want to thank you on behalf of all stroke survivors for doing that. And I know that you're a busy person, you have a family life and you have children and all that type of stuff. So I really appreciate your time. And I hope to be involved perhaps in the future when you guys do have data or things that you'd like to report, that you get in touch and let us know so we can share that information and tell people about it.
Oh, thank you. I think you're doing the real work. I think, just making sure that the stroke survivors are informed about what is going on in the field and being that bridge between clinicians and researchers and patients is really important. And so thank you for being that voice. We really appreciate it. I'm sure the stroke survivors appreciate it too. So thanks.
Thanks for joining us on today's episode. Now, to learn more about my guests, including links to their social media and other pages, and to download a full transcript of the entire interview, please go to recoveryafterstroke.com/episodes. If you would like to try the course 5 Foods to Avoid After Stroke, go to recoveryafterstroke.com/courses and get on board now. If you would like to support this podcast, the best way to do it is leave the show a 5-star review and a few words about what the show means to you on iTunes and Spotify. If you're watching on YouTube, comment below the video, like the episode, and to get notifications of future episodes, subscribe to the show. If you are a stroke survivor with a story to share about your experience, come and join me on the show. The interviews are not scripted. You do not have to plan for them. All you need to do to qualify is to be a stroke survivor or care for someone who is a stroke survivor, or you are one of the fabulous people that help stroke survivors. Go to recoveryafterstroke.com/contact, fill out the contact form, and as soon as I receive it, I will respond with more details of how you can choose a time that works for you and me to meet over Zoom. Thanks again for being here and listening. I really appreciate you. See you on the next episode.
Importantly, we present many podcasts designed to give you an insight and understanding into the experiences of other individuals. Opinions and treatment protocols discussed during any podcast are the individual's own experience, and we do not necessarily share the same opinion, nor do we recommend any treatment protocol discussed. All content on this website and any linked blog, podcast, or video material controlled this website or content is created and produced for informational purposes only and is largely based on the personal experience of Bill Gassiamas. The content is intended to complement your medical treatment and support healing. It is not intended to be a substitute for professional medical advice and should not be relied on as health advice. The information is general and may not be suitable for your personal injuries, circumstances, or health objectives. Do not use our content as a standalone resource to diagnose, treat, cure, or prevent any disease for therapeutic purposes or as a substitute for the advice of a health professional. Never delay seeking advice or disregard the advice of a medical professional, your doctor, or your rehabilitation program based on our content. If you have any questions or concerns about your health or medical condition, please seek guidance from a doctor or other medical professional. If you are experiencing a health emergency or think you might be, call 000 if in Australia, or your local emergency number immediately for emergency assistance, or go to the nearest hospital emergency department. Medical information changes constantly. While we aim to provide current, quality information in our content, we do not provide any guarantees and assume no legal liability or responsibility for the accuracy, currency, or completeness of the content. If you choose to rely on any information within our content, you do so solely at your own risk. We are careful with links we provide. However, third-party links from our website are followed at your own risk, and we are not responsible for any information you find there.